Polydipsia results from dehydration. As excess water is excreted in the urine, the fluid volume decreases. Then the brain's thirst mechanism alerts the patient to drink more fluid. Polyuria results from osmotic diuresis. As the blood glucose level rises, the kidneys try to compensate by excreting glucose into the urine. Because glucose is a large molecule, it pulls water with it. This produces large amounts of dilute urine. Polyphagia stems from cellular glucose deprivation. Because glucose can't enter the cells, they signal the brain's appetite center to increase food intake. But eating more food worsens the hyperglycemia by causing more glucose to enter the blood from the GI tract. Weight loss is caused by dehydration and fat breakdown. The latter occurs when the glycogen stores are depleted and the cells, desperate for fuel, signal the liver to convert fat to glucose. Also ask about other signs of hyperglycemia, including frequent infections, vision disturbances, and paresthesias in the hands and feet. Among diabetic patients, infections occur frequently and typically include infections of the skin, urinary tract, vagina, and any wounds. No one knows exactly why diabetes increases the risk of infection. However, some experts believe that hyperglycemia impairs phagocytosis, which is microorganism destruction by white blood cells. Others believe that hyperglycemia and acidosis lead to infection by creating an environment that promotes microorganism overgrowth. Diabetes may cause vision disturbances, such as blurred vision, because hyperglycemia alters eye structures, such as the lens, aqueous humor, and cornea. Paresthesias occur when excess glucose coats the nerve fibers. Over time, the coating interferes with nerve function, causing abnormalities, such as numbness and tingling in the hands and feet. Finally, assess your patient for signs of chronic complications of diabetes, which can affect nearly all of the body's organs. That's because uncontrolled hyperglycemia damages the arteries that supply those organs with blood. Here's how. First, hyperglycemia increases the risk of hypertension and hyperlipidemia. In the arteries, these conditions tend to injure the endothelial lining, allowing lipids to invade it. Second, hyperglycemia and other factors lead to smooth muscle cell proliferation in the injured arteries. This narrows the arterial lumen. And third, hyperglycemia makes platelets stickier, which increases platelet aggregation at the injury site. This impedes blood flow even further. All three events raise the blood pressure and impair blood circulation by increasing arterial resistance. Most chronic complications of diabetes are macrovascular or microvascular. Macrovascular complications result from changes in large blood vessels. To detect them, assess for signs of heart disease, especially coronary artery disease, cerebrovascular disease, such as cerebrovascular accident, and peripheral vascular disease, such as arterial occlusive disease, which can lead to foot ulcers. Microvascular complications stem from changes in small blood vessels. To spot them, be alert for signs of retinal disease, kidney disease, and nerve disorders. To evaluate the effectiveness of treatment, prepare your patient for diagnostic tests. When the tests are completed, review the results. In a diabetic patient, the blood glucose test is likely to show a level that exceeds 126 milligrams per deciliter on a fasting glucose test and 200 milligrams per deciliter on a 2-hour postprandial glucose test. In a patient without diabetes, the glycosylated hemoglobin test shows that 4 to 7% of glucose is bound to hemoglobin. In a diabetic patient, the test may reveal that 10 to 20% of glucose is bound to hemoglobin. That's because in poorly controlled diabetes, the blood glucose level remains higher for a longer time, allowing more glucose to bind to hemoglobin in red blood cells. The glycosylated hemoglobin test reflects glucose control and treatment compliance over several months because glucose stays bound to hemoglobin for the red blood cell's entire lifespan, which is several months. The urine ketone test may show ketones in the urine. When accompanied by a high blood glucose level, this is abnormal and signals ketoacidosis. After reviewing the test results and other findings with the patient's physician, work together to maximize the effectiveness of the treatment plan. Then discuss the plan with your patient. Treatment for diabetes mellitus consists of drugs, diet, and exercise. A patient with type 1 diabetes typically receives insulin subcutaneously every day to control his blood glucose level. Because this drug mimics endogenous insulin, it promotes glucose storage and helps prevent the breakdown of glycogen, protein, and fat. Depending on your patient's response to insulin, he may need rapid-acting, intermediate-acting, or long-acting insulin, or a combination of insulins. A balanced diet is a vital part of therapy for type 1 diabetes. Your diabetic patient should eat a diet that provides nutrients from all food groups, is low in sodium and cholesterol, and is high in fiber. A balanced diet typically includes 50 to 55% carbohydrates, 30 to 35% fat, and 10 to 20% protein. Your patient also should follow a regular exercise program to enhance the body's use of insulin. This patient with type 2 diabetes mellitus was admitted to your unit today for treatment of pneumonia. During your rounds, you notice that she's lethargic and difficult to arouse. You suspect that she may have hyperglycemic, hyperosmolar, non-ketotic, or HHNK syndrome, an acute complication of type 2 diabetes mellitus. In a type 2 diabetic patient, surgery or another stressor increases the body's need for insulin. Because such a patient can't produce extra insulin or use it effectively, the cells don't receive enough glucose for energy. Insufficient intracellular glucose triggers gluconeogenesis, which converts fat and protein into the glucose that the cells need. But without sufficient insulin to help glucose move into the cells, the blood glucose level climbs. If untreated, HHNK syndrome occurs, raising the blood glucose level dramatically. However, this syndrome does not cause ketosis. That may be because the pancreas still produces some insulin, which prevents the breakdown of fat into ketones. However, the pancreas doesn't produce enough insulin, which means that too little glucose reaches the cells. And this causes the liver to convert glycogen into glucose, raising the glucose level even higher than in DKA. That's why HHNK syndrome causes severe dehydration and neurologic dysfunction, killing about half of the patients it strikes. HHNK syndrome requires critical care and prompt treatment. So if you suspect this syndrome, work quickly to assess the patient and intervene rapidly. First, check the blood glucose and urine ketone levels. In a patient with HHNK syndrome, expect the blood glucose level to exceed 800 milligrams per deciliter. Next, assess the patient for signs of fluid and electrolyte imbalances, which occur when the kidneys excrete water and electrolytes along with glucose. Then replace the lost fluid by administering normal saline at the prescribed rate. During fluid replacement therapy, monitor the patient's urine output closely. When it reaches 60 milliliters per hour, expect to switch to half-normal saline solution to prevent hypernatremia. Plan to administer insulin as prescribed, usually at 0.1 units per kilogram per hour. When the patient's blood glucose level reaches 250 milligrams per deciliter, prevent hypoglycemia by switching to an IV solution that contains dextrose. As fluids are replaced, check the electrolyte levels and administer electrolytes if needed. When the patient's condition is stable, perform a complete assessment and review all test results as you would for a patient recovering from DKA. Be alert for signs of diabetes and its chronic complications. Also discuss your findings and the treatment plan with the physician and your patient. If a balanced diet and regular exercise don't control the blood glucose level, your type 2 diabetic patient may need drug therapy. Occasionally, she may need insulin, but usually she just needs an oral hypoglycemic drug from one of 3 drug classes. Sulfonylureas, such as glyburide, stimulate beta cells to produce more insulin. They also increase cell receptor sensitivity to insulin in peripheral tissues, which allows more insulin to bind with insulin receptors. Both mechanisms let more glucose enter the cells, which lowers the blood glucose level. Like sulfonylureas, biguanides, such as metformin, increase cell receptor sensitivity to insulin. In addition, they suppress glycogen formation in the liver, which reduces gluconeogenesis. Alpha-glucosidase inhibitors, such as acarbose, delay carbohydrate breakdown and GI tract absorption, which lowers the blood glucose level. When used in combination therapy, these drugs may let the patient receive smaller dosages of other oral hypoglycemics or insulin. Whether your patient is recovering from DKA or HHNK syndrome, individualize her nursing care, but expect to perform these general nursing interventions. Check the patient's blood glucose and urine ketone levels at least every 4 hours. Assess electrolyte and ABG levels as well as the results of other tests. Monitor the patient's fluid intake and output to evaluate fluid replacement. Watch for signs of complications, such as hypoglycemia, and ensure that the patient receives a balanced diet. Before your patient is discharged, teach her and her family how to control diabetes and prevent complications. Be sure to cover medication use and side effects, diet and exercise changes, blood glucose and urine ketone testing, signs, symptoms, and treatment of hyperglycemia and hypoglycemia, health maintenance activities such as eye and foot care, and follow-up care. As you have just seen, diabetes mellitus is a complex disorder that affects all body systems. If uncontrolled, it can lead to life-threatening complications such as DKA and HHNK syndrome. By understanding the pathophysiology of diabetes, you can recognize its complications swiftly and accurately, intervene with confidence, evaluate the treatment's effectiveness expertly, and help your patient control the disorder. Armed with this knowledge, you can provide the best possible care for your patient and help her live longer and better with diabetes.